Okay, everyone, let's start by grounding ourselves. Just take 20 seconds or so. Think of a patient, maybe a preceptor, someone who's genuinely shaped your path as a pharmacist. Take a moment, send them some silent gratitude. Feel your breath slow down a bit as you bring them to mind. Let's really honor that inspiration because today we're diving into, well, one of the most clinically relevant and frankly heavily tested topics on the Ellipowis. Now, what if I told you that one of the most over-prescribed drug classes out there in outpatient care, it often starts with just one single critical misdiagnosis, that you could potentially shave precious minutes off the clock during your NAPLEX and, more importantly, really impact countless patient lives just by knowing when not to treat. That's right, upper respiratory tract infections, URTIs. They might look pretty straightforward, on the surface, until you're facing a real-world clinical case where timing, drug choice, and those notorious resistance patterns all kind of collide. So in this deep dive, we're going to break it all down from otitis media to pharyngitis and really get into why your sharp antibiotic knowledge isn't just about passing an exam. It's truly about making or breaking patient outcomes. Okay, so let's unpack this clinical puzzle. We're tackling URTIs, which are, a cornerstone of ambulatory care. Especially given the widespread challenge of antibiotic overprescription, our insights today, they're pulled directly from McGraw-Hill's NAPLX review guide. So we've got a focused look at acute otitis media, acute bacterial rhinosinusitis, and acute pharyngitis.
Yeah, and what's truly fascinating here, I think, is just how often URTIs are actually viral, meaning, antibiotics are completely unnecessary in those cases. We'll try to arm you with the strategies for when you can confidently hold off on antibiotics and conversely, when to, well, fire away, focusing on those crucial factors like patient age, symptom severity, individual risk factors too, and we'll also try to embed those quick recall strategies for dosing principles and, the red flag symptoms you absolutely need to catch.
Okay, let's kick things off with acute otitis media, AOM. This is basically inflammation of the middle ear, and it holds the, well, somewhat infamous title of being the most common reason kids get antibiotic prescriptions. But here's where it gets really interesting and where you, as a pharmacist, can be a true champion of good care. Knowing the precise difference between AOM and otitis media with effusion, or OME, getting that right can literally save a patient from unnecessary antibiotics.
Exactly. AOM is a symptomatic middle ear infection. It's got that rapid onset, clear signs of inflammation, fluid behind the eardrum, OME. That's just fluid in the middle ear without those acute symptoms.
Right. So no inflammation, no acute pain necessarily.
Correct. And antibiotics, they're only useful for AOM. Making that distinction isn't just, textbook stuff. It's fundamental to responsible prescribing. It saves kids from side effects, helps reduce resistance. Every time you help clarify that, you're doing good work.
Yeah, absolutely. So how does AOM actually start?
Well, the journey often begins pretty subtly, usually after a viral infection in the nasopharynx, like a common cold. This viral thing kind of inflames and gums up the eustachian tube. That's that tiny drain pipe from the middle ear.
Okay.
And when that tube isn't draining right, fluid pools back there. Creates a perfect little swamp, really, for bacteria to move in and start their own party.
Makes sense.
And kids. They're uniquely prone because their eustachian tubes are naturally shorter, more horizontal, just less efficient at drainage. Plus, we see higher rates with things like bottle feeding, pacifier use, definitely daycare, and exposure to cigarette smoke.
Okay, so on the microbiology front then, we know viruses like RSV, influenza, rhinovirus, adenovirus often kick things off, or they're hanging around with bacteria maybe more than half the time. But we still need to know the main bacterial culprits we're actually fighting when antibiotics are needed.
That's a really powerful point about the viral role. But how do we as pharmacists confidently bridge that gap from it's probably viral to, okay, this definitely needs an antibiotic? It comes down to identifying those specific bacterial players. And the three most common ones are Streptococcus pneumonia, Haemophilus influenza, and Moricella catarrhalis.
Got it. Strep pneumo, H-flu, MCAT.
Exactly. And here's a critical clinical pearl. If a patient isn't improving on an antibiotic, maybe after a few days, it might actually be that underlying viral infection just persisting, not necessarily antibiotic resistance kicking in yet.
Interesting point. Okay, before we move on, let's solidify that. Quick check-in for everyone listening. Which three pathogens are the most common causes of acute otitis media? Is it A/S pneumonia, H. influenza, M. catarrhalis, B. E. coli, K. pneumonia, S. aureus, C. RSV, adenovirus, coronavirus, or DGAS, EBV, influenza? Slight pause. Okay, the answer is A/S pneumonia, H. influenza, and M. catarrhalis. Hope you get that one. So once we've got a handle on the bugs, what's next? How does AOM actually show up in a patient, and how do we nail the diagnosis?
By the presentation, acute symptoms usually include fever, ear pain, otalgia is the term irritability, and in little ones, often that telltale ear tugging. A look with an otoscope typically reveals a gray, bulging, non-mobile eardrum.
Okay.
And the formal diagnosis requires that middle ear effusion, plus either moderate to severe bulging with new ear discharge, or mild bulging, but with new ear pain that started within the last 48 hours.
This is pretty specific criteria.
It is. And while serious complications aren't common, they can happen. Things like mastoiditis, bacteremia, meningitis, even potentially long-term hearing or speech issues.
Okay, so treatment goals, what are we aiming for?
Pretty straightforward, but crucial. First, alleviate pain and fever. Second, eradicate the bacterial infection if it's there. Third, prevent those rare but serious complications. And critically, fourth, minimize unnecessary antimicrobial use. That's huge. The decision to use antibiotics really hinges on age, severity, and how certain the diagnosis is. For kids under 2, antibiotics are often prescribed right away because they have higher rates of treatment failure without them.
Makes sense.
But for children 24 months or older, we typically reserve antibiotics for the more severe cases. That means a fever of 39 degrees C, which is 102 degrees ARFE or higher, or moderate to severe ear pain, or ear pain lasting at least 48 hours.
And what about non-drug approaches? I know watchful waiting comes up a lot.
Yes. Watchful waiting is a big one. It means monitoring for 48 to 72 hours, seeing if the AOM resolves on its own. And this isn't just about saving money, right? It significantly cuts down on resistance development, avoids antibiotic side effects like diarrhea.
Yeah, definitely important.
It's a great option for healthy kids without recurrent ear infections, but only if proper follow-up is really feasible and communication is good. Surgical options, like tubes, those are generally for recurrent AOM or chronic OME, especially if it's affecting hearing or speech.
Okay, so when we do decide on antibiotics,
amoxicillin is still the first drug of choice for AOM, assuming the patient doesn't have that purulent conjunctivitis alongside it and hasn't had amoxicillin in the last month or so.
And why amoxicillin?
Well, it's proven effective, it's safe, low cost, comes in suspensions kids will actually take usually, and it has a nice narrow spectrum. That's great for stewardship. We're talking high dose here, 80-90 milligrams a day for kids or 875 milligrams twice daily for adults. That high dose is key, especially for tackling potential resistance.
Right, and what if amoxicillin isn't the right fit, like treatment failure, or they just had it?
Then amoxicillin clavulanate is the go-to. Think Augmentin. That formulation covers those pesky beta-lactamase producing bugs.
Okay.
Just a heads up though, the clavulin part can cause more diarrhea. So sometimes formulations with a 14.1 ratio of amoxicillin to clavulanate are preferred to maybe lessen that GI upset.
Good tip. What about penicillin allergies?
It depends on the type of reaction. For delayed or milder reactions, oral cephalosporins are usually fine. Things like ceftonir, cefuroxime acetyl, cepodoxime proxtil. But if it's a severe allergy like true anaphylaxis, clindamycin can be an option.
Okay.
But, and this is vital, clindamycin only reliably covers S. pneumonia. It doesn't hit H. flu or MCAT well. And the oral liquid tastes, well, pretty bad apparently. Respiratory fluoroquinolones, generally reserved for severe allergies and usually after consulting a specialist.
And just as important, what should we generally avoid using empirically for AOM?
Definitely macrolides like azithromycin and trimethoprim sulfamethoxazole like Bactrim. Resistance rates, especially for S. pneumonia, are just too high these days.
Okay, good to know. And pain.
Acetaminophen or ibuprofen. Those are your frontline choices for pain and fever.
Simple enough.
But a big no-no for kids with fever, aspirin. Because of the risk, albeit rare, of Ray's syndrome.
Right, always remember that.
Topical anesthetic drops, like benzocaine. They can offer quick relief, maybe 30 minutes, but they're not for kids under 2. There's a risk of methemoglobinemia.
Okay.
And forget about decongestants, antihistamines, or corticosteroids for AOM. They just don't have a proven role. They don't help.
What about how long to treat? Duration?
Yeah, that's still debated a bit, the optimal duration. But most guidelines suggest 10 days is standard. However, for kids over 6 years old with just mild to moderate infections, a shorter 5-7 day course can be considered. And if using ceftriaxone, usually injectable, it's typically a 3-day course. Now, we absolutely have to talk bacterial resistance. This really impacts our treatment choices. For penicillin-resistant S. pneumonia, PRSP, the bacteria that basically changed the lock where the antibiotic penicillin or amoxicillin is supposed to fit. The target site, the PBP, is altered.
Okay, so the key doesn't fit anymore.
Exactly. So adding a beta-lactamase inhibitor like clavulanate, which only stops bacteria from breaking down the drug, it won't help if the drug can't even get it at that lock in the first place. That's why high-dose amoxicillin is still our main weapon against PRSP, trying to overwhelm that altered lock.
Right, makes sense.
But then you have H. influenza and M. catarrhalis. They often develop resistance differently. They produce lactamase enzymes, which do break down the antibiotic.
How they destroy the key.
Precisely. And that kind of resistance can often be overcome by adding clavulanate, like an augmentin, to protect the amoxicillin. It's a really fundamental difference in how these bugs fight back.
Okay, let's put this into practice. Quick scenario for you listening. A 3-year-old presents with ear pain and a fever of 39.5 degrees C on. What's the best next step? A, watchful waiting. B, start high-dose amoxicillin. C, prescribe azithromycin. D, recommend saline nasal spray only. Slight pause. All right, the correct answer is B, start high-dose amoxicillin. Given the high fever and ear pain, that points towards a more severe AOM presentation needing antibiotics. So what does this all boil down to for your practice? I mean, it's really about being incredibly precise. Diagnosis first, then targeted treatment.
Couldn't agree more.
Memory hook. So remember, no fever, no bulging, no drugs. OMI stays off the prescription pad. Okay, so we've seen how we navigate AOM, often in little ones. Now let's imagine maybe that same patient, but a few years older. Or maybe an adult. They come in with persistent sinus pressure, maybe a fever. How does our thinking shift? Let's talk rhinosinusitis.
Right. This is inflammation or infection of the paranasal sinuses and the nasal mucosa. And just like AOM, the vast majority of these cases, they're viral. Yet antibiotics are still frequently prescribed. Way too often, probably. The real clinical challenge here, the thing that often trips up even experienced folks, is telling virals apart from bacterial. The symptoms can look almost identical sometimes.
Okay, so how do we differentiate? What are the clues?
Well, viral infections usually get better or resolve within 7 to 10 days. We start suspecting bacterial sinusitis when symptoms hang around consistently without improving for 10 days or more. That's one big clue.
Okay, persistence.
Another strong indicator is what we call a severe onset. That means a high fever, 39 degrees C or 102 degrees of Fahrenheit or higher, plus that thick, purulent, gunky nasal discharge or significant facial pain lasting for 3 or 4 consecutive days right at the beginning of the illness.
Got it. High fever and purulence early on.
And the third pattern is that classic double sickening. The patient has typical viral cold symptoms, starts to feel a bit better, and then bam, they worsen again. New fever, worse headache, increased nasal discharge. That strongly suggests a bacterial infection piling on top.
Okay. And the bugs involved, are they similar to AOM?
Very similar. The main culprits are, again, S. pneumonia, maybe 40% of bacterial cases, H. influenza around 35%, and M. catarrhalis about 15%. There's also a growing prevalence of Staphylococcus aureus being found, especially in adults, maybe up to 10%. But, and this is crucial, routine empiric anti-staph therapy is not recommended. We don't add coverage for staph right off the bat.
Right. So treatment goals for sinusitis. Still focusing on stewardship.
Absolutely. Goals are reduce symptoms, definitely limit antibiotic exposure, eradicate bacteria if truly present, and minimize how long the person is sick. For mild disease, symptoms less than 10 days. Initial management should focus purely on symptom relief, analgesics, maybe saline rinses. Antibiotics are not routinely recommended because, again, most cases are viral and self-limiting, and even many bacterial cases resolve spontaneously. We save antibiotics for those persistent, worsening, or severe cases we just defined.
Okay. What about non-drug stuff or supportive meds?
Humidifiers, vaporizers, saline nasal sprays, or irrigation. These can help with symptoms. The evidence for them working alone is a bit limited, but they're generally safe, supportive measures. For meds, analgesics for pain and fever are key. Intranasal saline irrigation can help clear things out, and intranasal corticosteroids can be beneficial, especially for patients who also have underlying allergic rhinitis.
Now, what should we generally avoid giving for sinusitis symptoms?
Okay, this is important because they're often used.
Yeah.
Oral and intranasal decongestants, generally not found to be clinically effective for sinusitis itself, and they carry side effect risks, like raising blood pressure or causing rebound congestion. Antihistamines should also generally be avoided unless there's a clear allergic component. They can actually thicken mucus, potentially impairing sinus drainage, and the side effects, like drowsiness, often outweigh any minimal benefit for infectious sinusitis.
All right, so when antibiotics are indicated for bacterial sinusitis, what's the go-to now?
Amoxicillin clavulanate is now the preferred first-line choice. Augmentin again.
Okay, so not just plain amoxicillin anymore.
Right. That's a significant shift from maybe, 10, 15 years ago. Amoxicillin alone is no longer recommended empirically.
Why the change?
It's because of the increasing prevalence of those lactamase-producing bugs, particularly H. influenzae and Nemcatturalis. Amoxicillin alone just gets chewed up by them too often. Amoxicillin clavulanate gives you that broader coverage you now need, plus it has proven efficacy, a decent safety profile, and it's generally well tolerated, aside from maybe some GI upset.
Okay, MX-Clav, first line. What about penicillin allergies here?
Similar approach to AOM. If it's a non-IgE-mediated allergy, like a rash, then oral cephalosporins like Cefixime E or cefpodoxime, often combined with clindamycin for better strep pneumo coverage, can be an option. If it's a confirmed serious Ig-mediated reaction hives anaphylaxis, then your options include doxycycline, though remember to avoid that in kids under 8, or a respiratory fluoroquinolone like levofloxacin. And again, macrolides like azithromycin and trimethoprim sulfamoxazole, not recommended empirically. Resistance rates are just too high for the common players.
And definitely no Cipro, right?
Absolutely.
Good.
Avoid ciprofloxacin for sinusitis.
Yeah.
It lacks reliable activity against S. pneumonia, a major pathogen here.
Got it. Duration of treatment for sinusitis.
Typically mirrors AOM again. Usually 10 days is recommended, though some guidelines might suggest 5-7 days for uncomplicated adult cases. Now, special considerations. Similar to AOM, high-dose amoxicillin clavulanate, that 80-90 milligo-kilogram day dose in kids, or the higher adult doses, should be considered if you're worried about PRSP. When would you worry? Maybe geographic regions with known high resistance rates, patients under 2 or over 65, immunocompromised folks, severe infections, daycare kids, recent hospitalization, or recent antibiotic use. All red flags for resistance. And again, clindamycin is useful for PRSP, but offers no activity against H. flu or MCAT, so it's not ideal monotherapy unless strep pneumo is confirmed or highly suspected as the sole pathogen. If treatment fails, meaning symptoms worsen after 2-3 days or just don't improve after 3-5 days, you need broader coverage. Options include high-dose Amoxiclav if standard dose was used, maybe levofloxacin, or potentially a combination like a cephalosporin plus clindamycin.
Okay, time for another challenge question for you. Think about this one. Which of the following is true regarding the treatment of acute bacterial sinusitis? A. Macrolides are first-line agents. B. Antibiotics are needed for all cases. C. Amoxicillin clavulanate is preferred empirically. D. Ciprofloxacin is superior for S. pneumonia. Pause to consider. All right, the correct answer is C. Amoxicillin clavulanate is preferred empirically. This really hammers home that shift in practice due to resistance.
Yeah, absolutely. And if we connect this to the bigger picture, that shift, from amoxicillin alone to amoxicillin clavulanate for empiric treatment, it truly reflects this continuous dance we have with bacterial resistance. It's not just about what used to work. It's about what's working now based on current resistance data and what we need to do to preserve effectiveness for the future.
Well said. Memory hook. So, the takeaway. If it walks like a virus and quacks like a virus, don't throw amoxicillin at it. Wait for those bacterial clues. Okay, one more major URTI to cover. Let's move down the throat to acute pharyngitis, sore throat.
Right. Acute pharyngitis is just an acute throat infection. Can be viral, can be bacterial, and most often it's the kind of thing that just clears up on its own in a few days.
So mostly viral again?
Overwhelmingly, yes. Viruses are by far the most common cause, but the main bacterial player we worry about is group A hemolytic streptococcus, or GAS, also known as Streptococcus pyogenes. That's what causes strep throat.
Okay. And why is identifying strep throat so important if most sore throats are viral?
Because, and this is critical, even though the sore throat symptoms of strep often resolve on their own anyway, treating confirmed strep with antibiotics is absolutely crucial to prevent serious, albeit uncommon, long-term complications. Primarily, acute rheumatic fever, which can lead to permanent heart valve damage, and also peritonsillar abscesses, which are nasty pockets of pus near the tonsils.
Ah, okay. So it's really about preventing those downstream complications.
Exactly. It's important to note, though, that antibiotics are not effective at preventing a different complication called post-streptococcal glomerulonephritis, which affects the kidneys. That seems to happen regardless of antibiotic treatment.
Got it. Who typically gets strep throat, and what does it look like?
Highest incidence is in kids, typically school-aged, maybe 5 to 15 years old. Symptoms often include a really sudden, severe sore throat, significant pain when swallowing, fever, headache, sometimes even abdominal pain, nausea, or vomiting, especially in kids. On exam, you might see that distinctive redness in the pharynx and on the tonsils, maybe with patchy white, exudates pus. Tender enlarged lymph nodes in the front of the neck, sometimes a swollen red uvula or tiny red spots called petechia on the soft palate. Occasionally a sandpaper-like rash called scarlatina.
Wow, sounds pretty distinct. Can we diagnose it just based on those symptoms?
Ah, that's the tricky part. While those features are suggestive, relying on clinical signs alone is unreliable for differentiating GAS from viral pharyngitis. There's too much overlap. So this is a critical point. Diagnosis requires laboratory confirmation. Absolutely essential.
How do we confirm it?
You need a throat swab for a rapid antigen detection test, the RET or
Okay.
rapid strep test, and or a throat culture.
So the golden rule test before you treat.
Precisely. Conversely, testing isn't usually recommended if there are obvious viral features like a prominent cough, runny nose, mouth ulcers, or hoarseness. Those point away from strep. Also, testing isn't typically done in kids under 3 years old because strep pharyngitis is rare in that age group and their risk of developing rheumatic fever is extremely low.
Okay. What if the rapid test is negative?
Good question. If a rapid antigen test is negative in a child or adolescent, guidelines recommend sending a backup throat culture because rapid tests can sometimes miss infections, false negatives. But for adults, a negative rapid test is generally considered sufficient to rule out strep because the incidence of GAS and the risk of rheumatic fever are much lower.
Okay, makes sense. So goals of therapy for confirmed strep throat.
Clear goals. Eradicate the GAS infection, prevent those period of complications like abscesses, and crucially, prevent acute rheumatic fever. Also, shorten how long the person is sick and reduce spread to others. Importantly, antibiotic therapy is indicated only for laboratory-confirmed strep pharyngitis with symptoms. No positive test, no antibiotic prescription.
Right. So if the test is positive, what's the drug of choice?
Penicillin V or amoxicillin are still the top choices. Why? Narrow spectrum, which is great for stewardship, low cost. Decades of documented safety and efficacy, specifically for strep pyogenes.
Okay.
Amoxicillin is often preferred for young children, mostly because the suspension usually tastes better and might be given once or twice daily, which helps with adherence.
What about penicillin allergies for strep?
If it's a non-IgE-mediated allergy, like a delayed rash, a first-generation cephalosporin like cephalexin is a good option. If it's a true anaphylactic penicillin sensitivity, then your alternatives include clindamycin, or macrolides like clarithromycin or azithromycin.
But you mentioned resistance earlier with macrolides.
Yes, that's a concern. There is increasing GAS resistance reported to both azithromycin and clindamycin in some areas, so local resistance patterns might play a role. Penicillin amoxicillin resistance in GAS is still basically non-existent, which is why they remain preferred. Clindamycin can also be particularly useful sometimes for recurrent infections, maybe if there's concern about co-pathogens or tolerance.
Okay. And duration of treatment for strep?
Typically 10 days for most oral regimens. That full 10 days is important for eradicating the bacteria and preventing rheumatic fever. However, one alternative for adherence is a single intramuscular dose of penicillin G-benzathine. One shot and you're done. That can achieve clinical and microbiological cure too. Dosing depends on weight.
All right, let's try another recall question. This one ties a few things together from our chat. In what situation should clindamycin primarily be considered for the URTIs we've discussed? A. Viral sinusitis. B. PRSP infections unresponsive to penicillin or maybe severe penicillin allergy. C. First line for pharyngitis. D. All pediatric sinus infections. Pause for a moment. Okay, the best answer here, thinking about its niche, is probably B. For those specific PRSP infections may be unresponsive to high-dose beta-lactams, or in cases of severe penicillin allergy where it covers strep pneumo, though remembering its limitations for H-flu and MCAT, also used for severe penicillin allergy and strep throat. All right, last one, a practical clinical scenario for you. What is the typical duration of therapy for uncomplicated AOM in a 7-year-old child? A, 3 days, B, 5 to 7 days, C, 10, 14 days, D, 21 days. Pause to think. The answer is B, 5 to 7 days. Remember, for uncomplicated mild to moderate AOM in kids over 6, a shorter course is often sufficient and recommended now. Member hook. Okay, for strep throat, the hook is lab test first, then treat strep, or risk the consequences of going rogue. Okay, so let's try to wrap this up. What does this all mean when we put it all together? We've really done quite a depth dive into this nuanced world of URTIs, from spotting the common bacterial culprits like S. pneumonia and AOM, tackling that tough clinical challenge of telling viral from bacterial sinusitis, right through to the absolute critical importance of lab confirmation for strep throat. It's a lot to juggle.
It really is. But the core message, I think, remains clear. The vast majority of these URTIs are viral and self-limiting. Our role as pharmacists is just absolutely vital in antimicrobial stewardship, knowing not just what to treat with, but crucially when to treat, and maybe even more importantly, when to confidently offer watchful waiting or just symptomatic relief. All of this while skillfully navigating that ever-evolving landscape of resistance patterns, PRSP, beta-lactamase producers, every single recommendation we make or don't make has a ripple effect on the patient in front of us and on public health down the line.
That's a great summary. So here's a final thought to leave you with, something to maybe mull over. Given these increasing rates of antibiotic resistance we see globally, how might future guidelines push us even further? Towards more personalized diagnostics, maybe? Rapid point-of-care tests distinguishing viral from bacterial right there in the pharmacy or clinic? Could today's watchful waiting, which sometimes feels like a secondary option, actually become the default, maybe even the gold standard, for many more conditions in the future? It's definitely something to think about as you continue your journey in pharmacy, because you, the listeners, are really at the forefront of this critical fight against resistance.